Did you know that 97% of physicians are already reviewing their patients' wearable data? Apple Watch, Oura Ring, continuous glucose monitors. But less than 6% have actually built it into how they practice, because there's no way to bill for the time that it takes to review it, and CMS just told us so. I spent years coordinating a family member's care, and what drove me absolutely crazy was that there was no system that pulled everything all together, even though it already existed. And that's basically the story in this video, except it's happening at the federal policy level now. Two big healthcare stories that broke last week were from CMS and the AMA, and together they explain why AI adoption in healthcare keeps stalling, even though the tech and the physician demand are already there. CMS has already built its outpatient payment system around physical resources like supplies, equipment, and staff time. But they never built one to price a product whose entire value comes from a proprietary algorithm. That's from the 2027 Hospital Outpatient Prospective Payment System rule that the CMS published on July 2nd, 2026, and as of the time of this video, it's still a proposal, not an actual settled policy. The new category that the CMS is proposing is Software as a Medical Service, or SAMS. It covers things like AI retina scan analysis, echo-based heart failure detection, and AI-assisted cancer imaging. It's the first real attempt at a standardized Medicare payment structure for AI diagnostics. And this is important for sales conversations because the question is, will the insurance actually pay for this? It's an objection that vendors hear all the time. Currently, CPT remote monitoring codes require an FDA-cleared device that's used under a clinician-directed care plan, and they don't cover consumer-grade wearables. So if your doctor looks at your Oura Ring data during an appointment, there's currently no code for that time, and the AMA is asking CMS to create one. As I mentioned before, the AMA Medscape survey, with over 2,000 physicians in 6 countries, named the specific devices of Apple Watch, Oura, Whoop, and continuous glucose monitors. So this isn't a device adoption problem. Clearly, we've adopted wearables. It's a billing code problem. It's basically the second half of the infrastructure reimbursement story as the CMS diagnostics rule. Buried in this same CMS proposal is 10 algorithmic lab codes, like secondary computer interpretation of genomic sequences, are moving out of the clinical laboratory fee schedule, which doesn't apply to patient cost sharing, into the new software as a medical service track, which does. That means a test that used to come with no separate bill could start generating a copay. The UK has similarly interested physicians and nowhere close to the same usage because the billing pathway isn't there. The real bottleneck finally has a name. This is the patient-caregiver lens crossover, a policy detail that lands on someone's actual bill, but no one is explaining this shift to the people that are getting those bills. If you sell AI diagnostics, then your buyer's care teams need a script for this conversation. Reimbursement uncertainty is not just a vendor problem anymore. It's about to become a patient-facing one as well. If you build or sell AI diagnostics or remote monitoring tools, tell me the answer to this question in the comments. Is reimbursement uncertainty already coming up in your sales conversations, or is it still dressed up as something else? If that question made you wince a little, that's what the Health Tech Sales Audit is built to catch. It's a free breakdown of where your Series A or B go-to-market content is still avoiding the objections that your buyers are thinking about. And the link is in the description. And if you want to learn more about how buyer perception and clinical AI trust actually shape what's getting adopted, then watch this video next. Here's a sneak peek. Scaling AI is not about having more pilots. It's about turning the right pilots into governed, measured, and adopted clinical capability. And slightly earlier, he also said, success is not just going live. Success is when physicians use the tools because it makes their day better. When you put these two statements together, it dismantles something that costs health tech companies